Dr. Deborah Kesto, who is the WHO Director for Mental Health and Substance Use Disorders. She's unable to be with us on this platform today, but she will be well represented by the next speaker. But before the speaker comes in, I would like a video from her.
Hello, good morning, good afternoon, good evening. My name is Deborah Kestel. I'm the director of the Department of Mental Health and Substance Use at the World Health Organization. And unfortunately, I won't be able to join you at the session as originally planned. So I was gently invited to share with you a few words, some greetings and a summary of our perspective. And I just want to emphasize, we know 10% of children and adolescents experience a mental disorder. And we also know that during the current COVID-19 pandemic, the prevalence of emotional disorders and risk behaviors have increased, particularly among the most vulnerable groups. We all want to see this opportunity of increased awareness on children and adolescents' mental health to build back better. And so from WHO, we are working with partners to prioritize a few issues right now on strengthening programming for adolescents' mental health promotion and prevention. We are working also on improving guidance to countries on transforming mental health care services for young people with mental health conditions. And we are also working to try to strengthening workforce capacity to improve access to early interventions and scalable psychological interventions for children and adolescents with mental health and brain health issues. So we look forward to learning from your capacity building and research experience and to future collaboration with the Smart Africa Center. Thank you.
Thank you so much. I think that really gives us a good translation into our next speaker. So without further ado, I would love to invite one of our colleagues from Kenya, who we just actually saw in the previous panel, Dr. Manas Kumar. Dr. Manas, I won't be able to read her bio, but I want to let you know that she's a very well accomplished scholar, and I've known her for a long time now, and I'm very pleased to say she's a good friend of mine. So Dr. Manas is a senior lecturer at the Department of Psychiatry, Nairobi University in Kenya. Dr. Manas, thank you.
Thank you so much, William. It's my pleasure to introduce our next speakers. I know in the program you will see Dr. Florence Baingana, but she's also joined today by Dr. Chiara Servili. The focus of this panel is on child and adolescent mental health and sharing the WHO priorities. And the first speaker is Dr. Florence Baingana, who is a psychiatrist and public health specialist from the WHO African regional base, and she's a regional advisor for mental health and substance use. She's passionate about building strong mental health systems in the African region and other low and middle income countries. What I also know is that she co-authored the 2018 Lancet Commission report on mental health and sustainable development. And she will be joined, she'll be sharing this presentation with Dr. Chiara Servili, who is a child neuropsychiatrist by training and technical officer at the WHO headquarters, at Department of Mental Health and Substance Use. She's also acting as the focal point for child and adolescent mental health, brain health. And prior to joining WHO headquarters in 2010, she served in the Eritrea WHO country office, and she's also supported WHO regional office for the Eastern and Mediterranean region. I know Dr. Servili's work around the public health monitoring of developmental disabilities. She's also the brain behind the ongoing initiatives of caregiver skills training that I know both Dr. Baingana and Dr. Servili will talk about. So without much ado, Dr. Baingana, over to you, please.
Thank you very much. I'm going to share my screen. So thank you very much. I'm glad to be doing this presentation with Chiara, who has much more experience than I have for child and adolescent mental health, as well as the programming that WHO has to offer. But since this conference was on Sub-Saharan Africa, I know Deborah wanted to attend very, very much, but she thought maybe I should make the presentation, but I thought I would share it with Chiara. I've been listening to the presentations today. Unfortunately, I couldn't join you yesterday. Very impressive presentations and discussions and very interesting work. Before I start, before we get into it, I just want to make two big points. One is the number of young people that we have in the African continent. And globally, if we look at Asia, South Asia, and Africa, the number of young people in these two continents, it's yeah, a very big population, which is also going to influence what happens as the demographic shift continues to happen. So if we don't protect and promote the well-being of young people today, it will have repercussions on what the next few years are going to look like. The other one is about, after hearing all the research studies and the advice that you were given about different proposals that could be put in, I just wanted us to also think about translation and implementation science. So how do you move the findings that you are finding in your research studies? How do you translate those into policy and into programming, but also going into doing research studies on programming, for instance? I won't go into that too much, but yes, I just thought I would mention that to begin with. So what influences mental health and mental well-being? Their individual attributes, their social and economic circumstances, and their environmental factors. And all of them interrelate with each other. So it is not just one thing, but an interrelationship of the three, and I'm sure you're very familiar with that. And then the burden of mental health conditions in children and adolescents. Unfortunately, we don't have data that says specifically this number of conditions globally. But we do know that most mental disorders begin during childhood and during adolescence, during young adulthood. 1 in 10 children and adolescents experience a mental disorder. That means that's about 10%, quite a big number. Neuropsychiatric disorders account for 16% of the global burden of disease for adolescents and youth. And self-harm is the third leading cause of global disability-adjusted life years. One of the biggest concerns we have at the moment is suicide rates among young people. They are on the increase. In the African region, we may not be measuring, or we may not have a sense of the extent of this problem because of the stigma and the taboos that surround suicide. But definitely it is on the increase. And we know that the treatment gap exceeds 80% in many countries. The other issue I think I will mention is that of alcohol and drug use among young people. We have a lot of alcohol and drug use. We have a lot of heavy episodic drinking. And especially now, even during the COVID, we have anecdotal evidence that alcohol was being supplied through online marketing and sales and delivery to homes. And then people holding all-night parties. And so that is another big problem that we are seeing in the Africa region. The impact of children's, well, the impact on children's well-being and mental health. This leads to health risk behaviors, educational achievement, and school dropout. Sometimes we have some children dropping out, not because they don't have fees, but because they cannot cope, or they are being beaten because they are failing to answer questions, or maybe they cannot sit still. There are so many reasons why some children drop out, and yet the underlying condition may be a mental health condition. Stigma, discrimination, and human rights abuses. There's also premature death, because we talked about suicide, but then there are other causes of death. Daily life, participation in society, and personal achievement. When young people have mental health conditions, these impact on all these areas. And of course, we know about the economic cost, the economic losses. When we talk about the mental health workforce in relation to child and adolescent mental health, I think you have talked about it already. But on the left-hand side, you can see that generally, I think you can't talk about a child and adolescent mental health system without talking about the health system in general. And we know that the health systems in Africa in general are underfunded. But on top of that, mental health per se is also grossly underfunded. So in most countries, 0 to about 1% of the health budget is allocated to mental health. Of this, almost nothing, I will say, goes to child and adolescent mental health. If we look at human resources, 0.9 of a person, that's less than a person per 100,000 of the population for general mental health. But on the right-hand side, when we look at the breakdown of the cadres, you can see that for the Africa region, 0.7 are psychiatrists. But when you look at child psychiatrists, you can't even see the line there. So we have 0, probably almost 0, child psychiatrists, child clinical psychologists, all these other cadres, even other specialist cadres, and that's an important thing to note. So the barriers and opportunities to addressing the treatment gap include availability of skilled or unavailability of skilled human resources. This is the key barrier to scaling up. Not just the numbers, but I would say also the geographical distribution. We tend to find that the specialists are located in the bigger cities, and the rural areas where most of the population is do not have any of the specialists that we would require to look after children. The identification of strategies for improving children's access to evidence-informed interventions by trained providers are among the top research priorities for improving the lives of individuals with mental illness. I also feel like there was mentioned that there's some work going on within schools, but for most countries and even where this is happening, I think we do miss the opportunity to strengthen school mental health programming. I know Rwanda is trying now. They are trying to do assessment of all school-going children in primary school to assess them for depression and then provide an intervention. But many other countries have not yet got to that level where they say we need a universal intervention, or we need universal screening, or even targeted screening for children who look like they may need to be screened. So that's a huge opportunity lost when you consider that 90% of children are in primary school, are school going, and 60 to 70 are in secondary school. So we tend to look at those not in school and say we need to get them in school, but let's also address those who are in school and use that low-hanging fruit. There's also emerging evidence on the effectiveness of primary healthcare level and community-based child adolescent mental health interventions delivered by specialists and or non-specialists. There has been a lot of this going on. I know in Liberia, they have trained child adolescent mental health clinicians who are based in the schools, and it is actually quite effective. But other places, they will train them and they will be based in the community or at the primary care level. I will now hand over to Chiara. Thank you very much. Chiara, should I proceed the slides for you?
Thanks, please. Thank you very much. I'm very delighted to be here today and have the possibility to join this conference and contribute to the WHO team presentation. I have the task of providing a few considerations that provides really the underpinning, the theoretical framing for WHO's work and priorities in this space of child and adolescent mental health, and then provide a brief overview of the different projects and the streams of work that we are currently active with and that could be used in countries and the products that could be used in countries. So the first consideration, I think, relates very much to some of the remarks made by Vikram Patel yesterday. So this slide is really to highlight how much the brain science informs our thinking around how to, what should be a priority for us. In terms of making sure that the environment where children and adolescents grow up is an enabling environment, because the quality of the environment throughout childhood and adolescence is really important to predict trajectories in terms of health, but also education and quality of life. The next slide, please. The next slide, please. Should I?
Yes, I'm trying. It's failing to move. I'm not sure why. Oh my goodness.
So I can keep going in the meantime. So the next slide is, providing the nurturing care framework. I think it's the previous one. Based on the brain science, WHO, UNICEF and partner developed in consultation with many experts and civil society organizations, a framework that is called the nurturing care framework that defines the critical elements, some of the key components around in terms of actions on the ground to ensure that children are supported by an environment that is enabling and nurturing for them. The next slide, please. Based on this assumption, there has been, really a rethinking or a redesigning of the child health agenda. And this has been very nicely described and illustrated in the 2019 Lancet Commission paper on realigning child health in the SDG era, really, redefining how the global public health agendas for child health should move away from a narrowly focused priority on addressing communicable disease and reducing mortality in early childhood or under 5 kids, to really embracing a whole of society approach towards improving, trajectories and improving the health and well-being with actions and sustained supports throughout childhood and adolescence. The next slide, please. And I think, the really, the good news for, those of us that are really, very strong advocate and passionate about child mental health is that this redesigned agenda on child health does encompass now, does include a focus and, and attention around the well-being and mental health. So we have really, moved away from a focus on the survive agenda to really talk about, what is required to thriving and also transforming societies so that really the environments around children and adolescents are those that they need to support their social and emotional learning, as well as to protect them from early adversities. The next slide, please. The second framework is the ICF the International Classification of Functioning, Disabilities and Health, that really reminds us how, we should really thinking, in a comprehensive manner about promotion of optimal functioning. So again, thinking transdiagnostically, not really focusing on the symptom-based approach, what is not, or, the developmental delay in a specific domain, but, really talk about, the profiles, the overall profiles of children in terms of development and emotional competencies in the context of their ecology, the family and the school and the community, and what is, required, in the entire, ecosystem of the child and adolescents to improve the overall functioning and participation of that particular child at that particular moment, with full recognition of the role of environment and changing environment and environmental actions to improve the mental health and the well-being of children and adolescents. The next slide, please. And the last theoretical type of consideration is to remind us about, the fact that children also do have rights. The Convention on the Rights of the Child and the Convention on the Rights of the Persons with Disabilities are two critical international frameworks that we refer to, and that reminds us about the need to prioritize again and again the actions on the ground that can ensure that first of all, children have access to the basic supports, are protected, they live in a safe environment, and this includes consideration for children with disabilities, particular that may be even more vulnerable to neglect, abuse, or to be institutionalized. This also applies to the standards of care in for children with developmental disabilities or mental health conditions, making sure that the care is provided in a way that is respecting the rights of children, carers, and the families, and in line with these conventions. The next slide, please. So this second part of my presentation is providing really an overview of the different projects that various colleagues in the Department of Mental Health and Substance Use at WHO are working on, along with many partners. The first project is called the WHO Quality Rights, and this is really having at the heart of it the purpose of promoting human rights and recovery and combating stigma and discrimination. It uses different strategies, from increasing advocacy, to supporting civil society movements, to conduct advocacy, to influencing policy making and reforming national policies and legislations for them to be aligned with those international frameworks and standards. The next slide. And there is a needs training available on quality rights capacity building that, it's really powerful capacity building tool for those that, are able to influence, these attitudes, the standards of care and the environments, again, for persons, including children and adolescents. The second stream of work relates to strengthening health systems with a critical component, really, critical focus on strengthening the workforce development, so the capacity on the ground. As Florence has mentioned, there is a huge gap in access to care. But also, and one of the reasons, one of the key barriers is the unavailability of skilled care personnel, or, the unavailability of network of professionals that can deliver evidence-based care to those kids when they need those specific supports. The next slide, please. Many of you, would know the MHGAP intervention guide that, is this WHO guidelines for non-specialist providers to equip them with the knowledge and skills for them to be able to adopt evidence-based practice in their daily job at the primary healthcare level and even community level as they assess and manage what we call as priority mental, neurological, and substance use conditions. There is a specific chapter for children and adolescents that provides guidance to non-specialist providers, including community workers, and nurses, GPs, for them to be able to recognize developmental delays and developmental disabilities or emotional problems and behavioral problems, and with guidance on what can be done at the level of the primary health care, what guidance, what psychoeducation, what psychosocial interventions would be useful so that it can really facilitate building up a network of care providers that can deliver the different elements of the evidence-based care that can benefit that particular child or adolescent and the family. The next slide, please. There is some experience with implementing the MHGAP. I want to mention here, those experiences where WHO has been more closely involved with. One example is in Uganda, where there has been, MHGAP has been implemented, and there has been also a research component undertaken within the implementation of the MHGAP. It has shown that the MHGAP implementation has resulted in an increased number of persons with mental health concerns seeking care. Interestingly, when we look at the research component that assessed specifically the capacity to identify child and adolescent mental health cases, or children with child and adolescent mental health issues, there has been an increase in the capacity of primary healthcare providers to identify those, but that was not significant. I think what is also very important to me is that in the context of the African region, there have been a couple of attempts to really use the MHGAP to build the capacity of the care providers in a more sustainable way. So really, by integrating the MHGAP within College of Medicine's curricula, or the curricula of College of Nursing, as well as part of postgraduate master programs for child and adolescent mental health. This experience, I'm referring particularly to the experience with Liberia and with Ibadan University in Nigeria. The next slide, please. When we say, we need to equip the workforce, the healthcare providers with the right set of skills and knowledge, we are particularly concerned, first of all, we want them to be able to recognize if there is a need for a family or a child to be supported a bit more in terms of development, promotion of development and well-being. But we also, need to make sure that there is good capacity to support the family and the children and adolescents with psychosocial interventions, because we know that this is the key strategy for helping children and adolescents and families, along with more structural type of interventions and intervention at the level of the environment to improve the quality of school environments and in the family and so on. But at the level of the individual, and the carer, psychosocial intervention is really, is critical. And, there is really, a challenge, when we think about the capacity of families and children and adolescents to access evidence-based psychosocial interventions in many, many settings. So the WHO has really try to bridge this, to address this gap by making available some scalable psychosocial interventions. So try, to really build on the available evidence to come up with psychosocial intervention that would be brief enough to be, incorporated into the available health systems, and for them to be really, scaled up even in low resource settings. The next slide, please. One example of these psychosocial interventions or scalable psychosocial interventions is the Thinking Healthy program that was, developed by Atif Rahman for the context of Pakistan and subsequently adopted for global use. The next slide, please. This is, really, having a focus on promotion of early childhood development and addressing maternal mental health in the perinatal period. The second example is a WHO caregiver skills training program that Manasi alluded to. This is another psychosocial interventions specifically for children 2 to 9 years of age with developmental delays or developmental disabilities. The strategy implies no specialist facilitators to meet with groups of caregivers, in 9 sessions, as well as, having the facilitators meet in the homes of the families. And the purpose is to strengthen parenting and capacities to promote the well-being of the child, the development of the child, by enhancing the capacity of the caregivers to use play and other daily activities as an opportunity to engage the child and really, promote communication and promote adaptive behaviors, with, of course, attention also to the well-being of the caregivers themselves. An online version of this program, the online CST or caregiver skills training, is currently available and is going to be field tested this year. The next slide, please. There is the CSC, the Caregiver Skills Training Program, has been field tested in a few sites in the African region, including Ethiopia and Kenya particularly, and it has shown in these pilot research studies, pilot RCTs, they have shown a good feasibility and that the program is relevant and is well accepted by the caregivers and families. In the context of Kenya, it has shown a decrease in behavioral problem scores for children who participated in the CST and enhanced scores on family quality of life measures. What I think is very important also is that it shows that when implemented, it can really empower caregivers for them, to contribute to broader changes in the environment where they live. So it seems that, there is an influence, beyond the strengthening parenting skills, but, really, in terms of empowerment, the caregivers to ask for more services and, for them to really change attitude in relation to what to expect of children with developmental disabilities and in terms of improving their quality of their own life. Next slide, please. Another example of psychosocial interventions being field tested is the EASE, Early Adolescent Skills for Emotion, targeting young adolescents 10 to 14 years of age, adolescents with emotional distress and impaired functioning. It is a group-based, manualized psychosocial interventions, again delivered by no specialist, over 7 weekly sessions with young adolescents, as well as 3 sessions with the caregivers. It has been tested or is being tested in a few sites. There has been a feasibility implementation study conducted in Tanzania, that has shown good feasibility of the program. And the RCT in Jordan has shown is the first full RCT to be completed, and there are positive results in terms of the effectiveness in terms of reducing symptoms in those adolescents attending the program. The next slide, please. Another psychosocial intervention, again for adolescents, but this time is for older adolescents, 15 plus, is the STARS intervention. This is a technology-supported intervention for adolescents with emotional distress. It's using a chatbot as an opportunity to facilitate interaction with those adolescents that require, that can benefit from some psychosocial interventions and support. It has been co-designed by adolescents, including adolescents in the South African context, and it has been field tested. Randomized controlled trials is starting in Jordan. Yes, so we are yet to see, the results of this full RCT. The next slide, please. The last psychosocial interventions, or the last project that I would like to mention, is the WHO UNICEF Helping Adolescents Thrive initiative. This is an initiative jointly by WHO and UNICEF with a focus on promotion and prevention in adolescent mental health for really, promoting well-being, reducing mental health conditions, and reducing risk behaviors in adolescents. The first product that has been made available of this package is a WHO guideline that provides evidence-based recommendations on psychosocial interventions for adolescents to promote well-being, to prevent mental health conditions and reduce risk behaviors. This has been released last year, and it addresses psychosocial interventions across delivery platforms, including in schools. It looked at universal interventions for all adolescents, as well as interventions for those adolescents, particular group that are exposed to adversities or special life phases, like pregnant adolescents or adolescents living with HIV/AIDS, as well as those with symptoms of emotional or behavioral problems. The next slide, please. I think it's my last slide. No, this is, just to tell you that there are 2 products in the pipeline to be released in May that are part of this HAT initiative. The HAT Toolkit, a programmatic guide that provides, the strategies for promotion, prevention, and mental health, as well as a comic book and a teacher guide for promotion of social and emotional learning in schools for young adolescents. And my next slide, which should be the last one. And my last slide is to tell you 2 things. One is that, there is a very strong focus currently at the work of WHO mental health department around care services, as Florence has highlighted. We are currently reviewing good practices in strengthening or transforming care services for children and adolescents with mental health conditions. I would like to invite those of you that are aware of good practice examples and case studies in either designing or implementing, evaluating care services for children and adolescents with mental health conditions to reach out to us and communicate, to share, these examples that may not be captured in available peer-reviewed literature. And the last message is around, the joint program. We launched, WHO and UNICEF, launched or signed a joint program on mental health, psychosocial well-being, and development of children and adolescents last year with Dr. Tedros and UNICEF head of agency, Henrietta Fore. This is to say that the 2 agencies have committed to strengthen efforts and strengthen collaboration cooperation to really, leverage on each organization's assets to improve impact in countries. So we are about to roll out this program, which is a 10 years program. And of course, we'll work collaboratively with partners, including governments and civil society organizations and academic institutes to really, make this become reality and benefit children, adolescents, and families. Thank you very much again for this opportunity.
Oh, thank you very much, Dr. Servili and Dr. Baingana. We have slightly about 5 minutes or less, and I have two questions for both of you. Maybe I will direct the first question to Dr. Baingana from William Bayansi, who has asked about how the work of WHO can bolster. I'm just pulling out. Could you also talk about how WHO can build and strengthen South-to-South collaborations as well as North-to-South collaborations that are productive and mutually beneficial to the global citizenry? So that's, I wonder if Dr. Baingana, you are able to comment on that.
Yes, I can make a comment. The South-to-South collaborations are definitely encouraged. And we are actually already encouraging that or participating in different South-to-South collaborations. One example I can give very quickly is that Friendship Bench, which I hope most of you have heard about, initiated in Zimbabwe and now about to be replicated in Harare. So that's a South-to-South collaboration. But there are others. Right now, as an example, they are not in the area of child mental health, but I'm sure child mental health as well could do the same thing. We are working on mental health investment cases in Uganda and in Kenya and in Zimbabwe. And at one time, we hope to bring the three countries together so they can share with each other. So the economists with the expertise will then be able to replicate the work they have done in these three countries and go into other countries and replicate the work there. So these are just some of the few examples, but definitely South-to-South and South-to-North and North-to-South, all the partnerships are encouraged.
Thank you, Dr. Baingana. Dr. Servili, I want to direct one question from Professor Fred Somala, who's the PIs of the Smart Africa Hub, and he is thanking both of you, Dr. Baingana and yourself, and he is asking that with universal screening, like the one referenced for Rwanda, how will the country deal with stigma, especially if they only intervene with children and young people who are presenting with either mental or behavioral disturbances in the schools as such. I've lost his complete message, but do you have any comments on this? And as a follow-up, I just want to, because we have a limited time, I just want to say that the multiple family groups as an intervention, Professor McKay and embrace that spirit and its open access, and perhaps WHO might also like to look at that intervention and the findings for potential, sharing with the world if you think it's meeting your benchmarks and a number of things you've pointed out. So, thank you.
Yes, thank you for this opportunity to comment on screening. I want to, clarify here, that we are not actually recommending screening. I really, I'm absolutely, in agreement with the concern around, screening and the stigma related to that. I can give you an example, with the program on the CSC on caregivers for children with developmental delays and disabilities. The evidence is really based on family-based or paramediated interventions for children with autism and intellectual disabilities. But because of the concern around stigma, it was decided to, use a strategy for having families access the intervention that would be, less, the least stigmatizing that, we could offer. So, we are defining it as a developmental delays and, any concern by a family, about, the the fact that, they may benefit from such a program that strengthens parenting skills, for promoting their kids' development, can, give access to the program. And that is, as it is being, really, promoted in terms of the community. But of course, we are, kind of having a vision around a tiered approach to psychosocial interventions, that transition with smooth and flexible transitioning, and, with approaches that really, are tailored to the specific needs of and evolving needs of children and adolescents, without really having, trying, to really, destigmatize as much as possible, the participation to interventions.
Thank you. Thank you so much. I know our next panel is lined up. So I want to thank both of you and your team for the wonderful work you're doing and such an amazing set of policy practice work, and keep doing that and keep talking to us. And thank you so much for making time. And I'd like to invite Josephine to take it from here, please. Thank you.